Slideshow. So I'm Beth Martin, one of the continue to share, one of the hematologists, and have somewhat new to the field, but not to sickle cell disease and inflammation that is quite related. So it's a big topic. But what I've done is, because I wanted to include a primer on hematology, I put that at the end of the slides. So if people are interested in that, there is an additional slide deck at the end. I appreciate the opportunity to be here today. So, yeah. I have no disclosures. My goals are to refresh your knowledge of key issues in hematologic diversity as it applies to the patient denominator in assessing COVID responses. Some new findings of field of hematology that may impact long COVID. Understand issues with interpreting the APS panel, antiphospholipid antibody panel, and some safe driving and managing anticoagulation. COVID and cellular hematology. The biggest interest from the COVID field in hematology, by the studies, by responding to patients, was mainly in cells and neutrophils, monocyte, macrophage, and platelets, less so with red cells, but how these interact with each other and with coagulation factors. And I, as probably most of you here, hate to memorize the coagulation cascade, so we won't be doing that today. But there are some key features there that are important to look at when you're monitoring the literature. What's interesting now, though, and particularly with the outcomes in aging and long COVID, host factors have not been looked at, particularly clonal hematopoiesis that has a high association with arterial disease when we're over the age of 55. We still don't have a big role in red cells, but there may be some. And again, there's such complexity, but I think that there are some key areas that we found in hematology that raise the risk of vascular disease that I think are important. But also, I personally think, as with most adult human diseases, that neutrophil extracellular trap or net formation is going to be the underlying issue here, as our knowledge of this expanding. But juxtaposed to this is that as people have been monitoring, there's a remarkable amount of autoimmunity that develops. There's an increased incidence of immune thrombocytopenia, even a slight increase in thrombotic thrombocytopenic purpura. We saw VIT happening, and then the thrombocytopenia that's associated with arterial thrombosis in that situation. But then there's a tremendous interest in the antiphospholipid antibodies and how these are related to disease. So I'll pause for a minute and to look at these two pictures and to see if you know what these are. And for anyone who ate a pomegranate this morning, this is also how the arils in the pomegranate form, and when we chip those out. So this is actually how an arterial clot looks. This is in arteries and in arterioles, can be found in AVM bends, less so in veins, and it's because of the lack of vascular tone. But basically what happens is that as a clot forms, the fibrin and the platelets are extruded to the outside. The red cells change their shape. They're called polyhedrocytes, and they pack. So that's where the issue, again, with eating a pomegranate, that white membrane around, as it goes from liquid to polymerize, it packs those arils in, and the same thing happens in clots. And so this was first described in 2014. There were some abstracts in the years before that. It took very special equipment to find it. But it turns out with our lytic therapy and our own fibrinolysis in our bodies, we're just chipping away at the outside. And so a big movement forward, particularly for coronary artery disease, which is very, very active, this mechanism, will be to see if we can make the red cells more slippery and to have them return to their biconcave disc, which is a very flexible structure, rather than staying as these jagged, what are called polyhedrocytes. So very new on the scene. This is just a general cartoon. Many of you are familiar with this, that there are many hematologic aspects of long COVID, most related to some level of vascular dysfunction. And as we know, that most of our thrombosis in our bodies was designed to be anti-infective, to control intruders. I don't think our bodies were designed to live beyond the age of 30 to 35. Our ancient ancestors had to do two things: protect themselves from bleeding, so to be very prothrombotic, but also to fight infection. And so that's where that sol to gel of the fibrin clot can trap bugs and then allow the immune system more time to clear them out. But also, as we're finding, neutrophils will also greatly enhance that process to cause clotting. The other focus in the long COVID literature, but in acute and long, is the power of a D-dimer level in determining severity of disease. In this case, these were patients related to controls. This was from a very large study of thousands of patients, retrospective, and death was highly associated with D-dimer of over 3,000. I haven't shown that, but this is always a drumbeat in the background. And basically what D-dimer shows, as most of us know, is it means that fibrin is around somewhere and that our fibrinogenolysis and fibrinolysis is still trying to chip away at it. So the body sees something active that it's trying to get rid of. And the calling card for this is the D-dimer. It's also, just to review, some of the key coagulation factors and their timeline. I only included the ones that actually have a very high probability. This is also from an extremely large retrospective study from China from early on. But absolute lymphocyte count, platelet count, antithrombin 3, which is one of our natural anticoagulants, reduce. But even by 12 months, if you look from patients' baseline, they still have subtle thrombocytopenia or relative thrombocytopenia, even if it's above 150. And then we have a variety of factors that are vascular related that rise. So von Willebrand factor, which is basically like silly string that squirts out from the endothelium, and it binds factor 8, one of our key clotting factors, and it binds platelets. So it brings all that together. Our SED rate reflects fibrinogen, interleukin 6, very active cytokine, because again, through the macrophage interaction with the coagulation system, through the interaction of neutrophils with platelets, our cytokine inflammatory system is extremely activated. Prothrombin time in INR prolonged. Fibrinogen is high, so this is not classic DIC. It's called compensated, and again, D-dimer. And if D-dimer doesn't reduce to normal by 12 months, it's, and unfortunately, I'm about to lose power here, so I'll go on. Then we may be in a situation of long COVID. Pardon me for a minute. I was just talking about the importance, as you read about Pi1, all this sounds so exotic, but just think about what feeds forward in coagulation and then what is there to remodel and break down. And when we're breaking down, you pick up some of those modifiers. Pi1 can be tested clinically, but it's not very reliable. I'd like to move on to briefly mention a very important other disease that could be in the
Oh,
denominator.
Dr. Martin, could you share your slides?
Oh, sorry.
Thank you.
Thought I was sharing. Okay. Okay. There we go. So there's another disease that I'd like to briefly mention because it may be quite important in men over the age of 50 with long COVID, and that's VEXUS. And it's an acquired mutation in a gene called UBA1. The testing is easily obtained by many companies. Stanford does have two types of testing, but it's estimated now throughout the world that it's around 1 in 4,000 men. Overall, it's much less common because of X inactivation with women. But this is one to look out if you have patients who have unusual findings for new myelodysplastic syndrome, cytopenias, or new unusual rheumatologic disorders. And for you, Zara, particularly polychondritis is highly associated with it. So if they are coming in with nasal issues, pinnae issues, they could have VEXAS. And it's highly inflammatory. I want to talk about some big news about platelets. And these have been brewing now for around 10 years, but we finally have enough studies. This is new out this spring in our journal Blood, that it's been confirmed that we have several subtypes of platelets, and it mainly depends on the age. And these are people with normal platelets otherwise. They initially start out as hemostatic. So this explains why, if you've ever seen an ITP patient who comes in with a platelet count of less than 5,000 and yet they're not bleeding, those are super platelets. And they're very hemostatic. But as platelets age, they begin to acquire a coating of IgG and IgM. And that's also why it's non-covalent. But that's how most of our IgM is actually carried in our bloodstream, is it hangs on for the ride on a platelet. And then they develop an immune function because of that. They also are carrying angiogenic proteins, so they have multiple uses. But the other thing that you'll see if you look at my primer is that most of our coagulation actually takes place on the surface of an activated platelet. So envision that as this oil drilling well, bobbing out in the sea, and coagulation is going to happen on that, and it's tethered to the endothelium, or it's actually embedded in the endothelium because it's bound to collagen. But the other interesting and really cool thing is that in ITP patients, we could never figure out why they were at higher risk for DVT. Well, it turns out that one key way that we get rid of old red cells, so that's between ages of 85 days and 100 days, they're getting damaged. They've got stiff membranes. They can't through, they're very reactive. They actually get tagged by a platelet. There's a special receptor, and that one platelet, like a little tugboat, escorts the red cell to its death to a macrophage. So there's much monocyte and macrophage binding of platelets. This is one unique one. It actually may be at play in inflammatory disease like long COVID. Certainly in dramatic disease like ITP, it's been associated with increased DVT. But it also speaks to the fact that platelets cozy up to macrophages, and that's definitely been demonstrated in long COVID. But the other big breakthrough, and we have suspected this for over 25 years, but it's recently been proven, is that a significant proportion of our platelet production occurs in our lung, and it's in a space between the arterioles and the alveoli. And so it's huge breakthroughs in this just this spring in this area. And this is a cartoon showing lung and then where these sit. And these are actually hematopoietic stem cells that tend to differentiate towards platelets more than the other cell lines. I then want to move on to, I think, the key thing where we're going to see the research and actual therapy focused in diseases like long COVID and other diseases. And again, as I mentioned before, we now know that most of our vascular diseases in our body are actually related to neutrophils and to this process called netosis. This is just a very dramatic photo from cystic fibrosis, that what nets look like. And these are all DNA strands. People who give lectures on netosis, they always have a Spider-Man web as their first slide. And platelets attached to that. It's a sticky mess. And it surrounds organisms because, again, our body sees every invader as a microbe. Even cancers look like microbes to our immune system. And the other thing, though, that I'd like to commend and for everyone to know that this first was found in sickle cell disease. So for many years, we thought netosis only occurred in sickle cell disease. We've always known that those deformable red blood cells of sickle cell were related to the neutrophil count. And Chen and all investigators in 2014 had the first publication. So we can thank those authors for pushing forward with a very unpopular field at that time. And so what happens is that normally neutrophils are supposed to involute, go through apoptosis, that gets ingested by a macrophage. We do know that in pathologic states and sepsis, apoptotic bodies can be activating to the inflammatory system, so that's not a good thing if it's overdone. But it turns out that basically the neutrophil is triggered and it vomits up its chromatin, histones, partially uncoiled DNA. The strands are as long as 3 centimeters, whether it's a mouse or a man. These are very long single strands of DNA in a vessel, and platelets attach rapidly to this. As the DNA enzymes come through, they start to break down the DNA. But as many of you may know, and I'm not an immunologist, but there are toll-like receptors that take those nucleotides, and those will activate our cellular immune system. And so we are not supposed to have naked DNA to this level in our vessels. This is highly pathologic. And this is actually the underpinning of a sickle cell vaso-occlusive crisis and a microthrombi. And it turns out this is the underpinning of microthrombi in long COVID. I'm going to skip by this one. But what we do know is that the RNA of SARS-CoV-2 does enter neutrophils through a toll-like receptor. It triggers netosis through PAD4 protein, also called PAD14 protein. And again, we think that this is a key underpinning to the disease. NET detection for years has been available in FFPA and blood samples. Research kits are widely available. We still do not have a validated clinical NET detector, though. The other aspect is what happens in netosis is you release a lot of mitochondria from neutrophil and platelets. And that we think is what causes anticoagulopathy antibody formation. And that may in turn, as these are felt to be related to acute and long COVID and thrombosis, is the connection there. Let's see, I'm going to skip ahead for time, and I'm so sorry I got interrupted. So this is hot off the press this spring in a mouse model. This is a staph model, but they were actually able to show why there are waves of netosis. So one thing to know about a neutrophil, it's supposed to live only 20 to 24 hours. And in the sickle cell literature, in that growing long COVID literature, no one could figure out how these neutrophils were living so long. And there are subtypes of technically neutrophils or myeloid cells that are a differentiation pathway that can live longer. But what it turns out is that what sticks to the side of the vessel wall are histones, and we don't break down histones easily. So again, as I mentioned before, DNase comes in right away and starts to shatter all those sticky DNA, very strong, DNA strands, those 1 and 3 centimeter strands that are making truly a net. But the histones actually apply, and they are now finding in this mouse model there are multiple autoantibodies. Now they published this before they could parse it out to see if these were actually cardiolipin and beta-2-GP1. But I talked to the author, and they do have some evidence that that's a predominant type of antibody. So this again may be the link to why we form some well-known anti-endothelial and antiphospholipid antibodies in these settings. So I think this will just explode the field. So I want to go through a quick drill for antiphospholipid antibodies. They are reactive in a wide variety of diseases. And so when someone says antiphospholipid antibodies to me, we're only thinking syndrome, and it has very strict criteria. And so I think it's been hard for hematologists to accept this involvement. We felt initially it was just noise. But now that there's the link with netosis and what we think is an APS-like syndrome, or at least in microvasculature, I think hematologists are really going to accept that there are certainly circumstances where we can look at these as pathogenic even if they're not at a high level. So again, these reactive levels be important in COVID? But a big problem in research studies and everything that's published here at Stanford, at every institution in the country and the world that tests for these, the assays are not uniform and they vary among clinical labs. So if we do think here that we have someone with antiphospholipid antibody syndrome, we actually send it to labs to try to confirm it, and we repeat them again in 3 months because we don't want to keep someone on very high risk anticoagulation with very poor prognosis if we're not sure they actually have this syndrome. So when you read the literature, to be aware that there's this dichotomy, and that even after all these years, we don't have great testing. Now, if the pretest probability is very high, that you have high risk, extensive unprovoked thrombosis, you actually see livido racemosa, or some people call it reticularis. You biopsy it. They've got associated clear ITP. They've got active autoimmune disease. They have dual venous and arterial thrombosis, which may extend over years. They have very early advanced arterial atherosclerosis, particularly carotid. They have a renal TMA, atypical HUS picture. If you have patients like that and they happen to get COVID, this person may truly be tipped over into having the syndrome with a high rate of death. It turns out, though, our prolonged PTT, which is related to the lupus anticoagulant, is not an adequate screening tool. So you can't rule it out with a normal PTT. But again, in APS syndrome, we repeat the panels in 3 to 6 months. Now, clinically, in our practice, we only use an IgG level of greater than 40. We ignore IgM, but we're going to find out, I think, in the next couple of years, very exciting, whether IgMs are actually important in long COVID and other similar diseases. Seronegative APS does exist. That's a whole separate issue from what we're talking about today. But if you truly have a patient that you think has antiphospholipid antibody syndrome, they have recurrent thromboses, both venous and arterial, we really have to go with Lovenox or warfarin, and they have to be bridged. This is not a patient in between procedures that you can't bridge. You also, I think that lipoprotein A, which we only need one testing in our life above the age of 8, also programs us for more arterial thrombosis, and I think that should be a part of our normal lipid panel. To be aware, if you do have patients on warfarin, they have a lupus anticoagulant. They cannot have the fingerstick method done, and the PTT will never be reliable for positive if they have a positive lupus anticoagulant. It's very important for our surgeons when they're caring for these patients.
Oh, Dr. Martin, sorry
Uh-huh.
to interrupt. We're going to have to move on to the Q&A session, but I wonder if we
Okay.
can discuss some of this during the Q&A
Sure,
with the rest of
sure.
the group. That would be great. Sorry,
Great.
apologies
Thank you.
for the
No,
tight
thank
timing.
you. I'm so sorry for the interruption.